All right, if you're in med school or pharmacy school, you've heard fight or flight a million times, right? But what happens when we want to control that system with drugs? Well, that's exactly what we're diving into today. We're talking about adrenergic agonists. These are the powerful tools that can mimic and even boost our body's most fundamental reactions.
So at their very core, these drugs have a pretty cool name, sympathomimetics. And it's actually a super straightforward name if you think about it. They mimic the sympathetic nervous system's key messengers, norepinephrine and epinephrine. These are the agents that go in and flip the switch on our adrenergic receptors.
Okay, so to really get a handle on these drugs, we've got to build from the ground up. Here's our game plan. We'll start with the basic neurotransmission process, then we'll meet the key players, the alpha and beta receptors. After that, we'll get into the chemistry, comparing catecholamines and non-catecholamines. And finally, we'll bring it all together by looking at direct-acting, indirect, and mixed-action agonists.
All right, first up, adrenergic neurotransmission. Look, to really get how these drugs work, you have to understand the life cycle of norepinephrine, the body's own natural messenger. Seriously, every single drug we're going to talk about today messes with this process in some way, so mastering these steps is absolutely key.
Let's walk through this in 5 key steps. Step 1 is synthesis. It all starts with the amino acid tyrosine, which gets converted into dopamine right inside the neuron. Simple enough. Then step 2, storage. That dopamine gets packed away into these little vesicles, and inside them it gets converted into norepinephrine, ready to go. Okay, step 3, release. An action potential comes along, zaps the neuron, calcium rushes in, and boom, the vesicles fuse with the membrane and release norepinephrine into the synapse. Now for step 4, receptor binding. The norepinephrine floats across the gap and binds to receptors on the target organ. But, and this is cool, it also binds to receptors on the presynaptic neuron, which acts as a sort of brake, telling it, okay, that's enough. It's a negative feedback loop. Finally, step 5, inactivation. The signal can't go on forever, right? So norepinephrine gets cleared out. It's either sucked back up into the neuron by a transporter called NET, or it gets broken down by enzymes like COMT and MAO.
Okay, so we know how the message gets sent. Now let's talk about where it's received. We're going to start with the alpha receptors. A good way to think about these is as the body's main on and brake switches for a lot of the sympathetic system's actions. So there are 2 main flavors of alpha receptors, alpha 1 and alpha 2. And here's the kicker. They have pretty much opposite effects. It all comes down to the G protein they're hooked up to. Alpha 1 receptors, they're linked to a GQ protein. When you activate that, you get a boost in intracellular calcium, which is usually a stimulatory response. Think smooth muscle contraction. On the flip side, you've got alpha 2 receptors. They're tied to a GI protein, and you can remember I for inhibitory. This pathway actually lowers the levels of intracellular messengers like CAMP, which gives you an inhibitory response. So where do we actually see these effects in the body? Well, alpha 1 receptors are all over the smooth muscle in our blood vessels. When you stimulate them, you get vasoconstriction. The vessels clamp down and blood pressure goes up. You'll also find them in the eye, where they cause pupil dilation, and in the bladder, where they tighten the sphincter. Now, alpha 2 receptors, true to their inhibitory nature, you find them on the presynaptic nerve ending. When they get activated, they basically act like a shutoff valve. They stop more norepinephrine from being released, and that's that negative feedback loop we mentioned in action.
All right, moving on from the alphas, let's talk about the other big category, the beta receptors. These guys are absolutely critical for regulating the heart, the lungs, and our metabolism.
There's a really common mnemonic here that actually works. You have 1 heart, so that's beta 1, and you have 2 lungs for beta 2. Pretty handy, right? Beta 1 receptors are found mainly in the heart, and they kick up the heart rate and how hard it contracts. Beta 2 receptors are in the lungs, and they do the opposite of constriction. They cause bronchodilation, opening up the airways. This relaxing effect of beta 2 also happens in other places, like the uterus. And then there's beta 3. You'll find these in fat tissue, where they ramp up fat breakdown, and also in the bladder, where they help it relax. Oh, and one key thing to remember. Unlike the alphas, all the beta receptors are coupled to a stimulatory GS protein, so they all lead to an increase in intracellular messengers.
Okay, we know the targets. Now let's finally talk about the drugs themselves. Adrenergic agonists really fall into 2 big chemical families, catecholamines and non-catecholamines. And this is so important. Their chemical structure is basically their destiny. It dictates everything about how they behave in the body.
So what's the big difference? It all comes down to a specific chemical structure called a catechol group. The catecholamines, like our body's own epinephrine and norepinephrine, have it. And that group is a huge target for those enzymes we talked about, COMT and MAO. They just chew it up. Because of that, you can't take them orally, their effect is super short, and they're too polar to get into the brain. Now the non-catecholamines, they don't have that vulnerable group. This makes them tough. They're resistant to breakdown, which means you can take them orally, they last a lot longer, and because they're less polar, they can actually get into the central nervous system.
Okay, now we're really getting into the pharmacology. Let's start with the direct-acting agonists. The name says it all, really. These are the mimics. They bind directly to the alpha or beta receptors and turn them on, acting just like norepinephrine or epinephrine would.
And the classic poster child example here is epinephrine. It's a non-selective catecholamine, meaning it hits almost all the adrenergic receptors, alpha-1, alpha-2, beta-1, beta-2. And it's this all-of-the-above action that makes it such an incredible life-saving drug. Think about anaphylactic shock. Its alpha-1 action clamps down on blood vessels to fight the drop in blood pressure. Its beta-1 action revs up the heart, and its beta-2 action opens up the airways. It's the perfect combination for that kind of emergency. Now, norepinephrine seems pretty similar to epinephrine at first glance, but there's a huge difference. Norepinephrine is an absolute beast at activating alpha-1 receptors, which makes it a super potent vasoconstrictor. But, and this is the key, it has almost no effect on beta-2 receptors. Since it can't open up the airways, its use is much more specific. It's really for things like severe hypotensive shock, where the #1 goal is to crank up that blood pressure and fast.
Let's switch gears to a selective drug, Clonidine. This one's an alpha-2 agonist. Now remember what we said about alpha-2 receptors? They're the inhibitory brake on the presynaptic neuron. So what Clonidine does is it goes into the brain and hits that brake hard. By doing that, it actually reduces the total sympathetic signal coming out of the central nervous system. The end result? Lower blood pressure.
Okay, how about a beta-selective agonist? Let's look at dobutamine. This drug is really selective for the beta-1 receptors, which, as we know, are packed into the heart. This laser-focused action is what makes it perfect for something like acute heart failure. It goes right to the heart, tells it to pump harder and faster to boost cardiac output, and it does all this without causing massive vasoconstriction all over the body.
And of course, we have to talk about Albuterol. This is one you probably know. It's a selective beta-2 agonist. Its job is to find those beta-2 receptors in the lungs and tell them to relax the smooth muscle. The result is bronchodilation. It's that targeted action that makes it the go-to rescue inhaler for an acute asthma attack. It opens up the airways, and it does it fast.
All right, let's wrap up with our last two categories of drugs. Now these guys are a little different. They don't just mimic norepinephrine. Instead, they kind of work behind the scenes to crank up the amount of it that's hanging around in the synapse.
So the indirect acting agonists are pretty clever. Instead of binding to the receptor themselves, their whole game is to stop norepinephrine from being cleared away from the synapse. It's like they turn up the volume on the body's own signal by not letting the sound fade out. And the classic examples here, amphetamine and cocaine. What they do is block that net reuptake transporter we talked about way back in step 5 of neurotransmission. By plugging up that vacuum cleaner, you leave way more norepinephrine and dopamine floating around in the synapse. And that leads to some very powerful stimulation, both in the sympathetic system and in the brain.
And then you have the mixed action agonists, which, as the name suggests, do a little bit of both. Drugs like pseudoephedrine and ephedrine will bind directly to the receptors, but they also poke the neuron and make it release more of its stored norepinephrine. For a drug like pseudoephedrine, the end result is vasoconstriction in your nasal passages, which is exactly why it's such an effective decongestant.
So when you put it all together, what's the big takeaway? It's this. The effects of these drugs are not random. They are incredibly predictable. If you understand just two things, their chemical class and which receptors they target, you can pretty much figure out what they're going to do, what they're used for, and even what their side effects will be. It's a really logical system, not just a bunch of facts to memorize. And that brings us to a final and really important clinical question to think about. We use these drugs for a specific reason, right? Like using albuterol to open the airways. But since they all tap into that fight or flight machinery, what predictable side effects do you think a patient might run into? Being able to answer that question, that's the next step to really mastering this material. Thanks for joining me for this breakdown.